All right. Good morning, everyone. Welcome to Pediatric Grand Rounds. Thank you for joining us. Today's presenter will be Dr. Andrew Miller, one of our soon-to-be graduating PGY3s. Dr. Miller came to us as a graduate of North Carolina State with a degree in biomedical engineering. He also completed a Master's of Art at Duke School of Divinity with a fellowship in theology, medicine, and culture. He completed his medical education at UNC SOM. While at Carilion, he completed QI projects to increase health literacy and served on the ethics committee and as part of the ethics consult team. Dr. Miller will be returning to Durham, Duke Regional Pediatrics, outpatient, and Associate Professor of Biomedical Ethics at the Duke School of Divinity. Please join me in welcoming Dr. Andrew Miller.
Thank you so much, Dr. I want to say thank you all for joining me for Grand Rounds this morning. In typical Andrew Miller fashion, there's going to be a little bit of medicine, a little bit of ethics, a little bit of philosophy. We're going to kind of cross all over the board here. So I hope that is something that you're interested in. I am a Hamilton fan, and I just think it's so brilliant. So I've obviously made the starting slide here to mimic that. The title comes from obviously the song "The Room Where It Happens" in Hamilton, referring to Burr missing out on the meeting with Jefferson and Hamilton. But I think it's salient because what we've done with our infants is we always want to be with them. We're obsessed with knowing everything about them, even the teeniest, tiniest little nuances, piece of information. And so that our modern technologically driven society has created opportunities for us to do that, and it drives the room where it happens. We always want to be in that room with our child. And so what this Grand Rounds is going to be focusing on is a couple different things. So we'll start off with a review of pulse oximetry technology, some of its indications and uses, how its technology works. We'll then transition to a little bit about baby monitors and the history of baby monitoring systems. We'll go through kind of their use, how good they are, how bad they are, and then some of the kind of marketing strategies surrounding them, and then also kind of some other perhaps not well thought of consequences of these monitors. So that's our roadmap, and with that, we'll get started. Disclosures. I'm going to use some product trade names in this presentation because there's no generic version of an Owlat, or the other ones. So because of that, I'm going to use their trade names. I don't care if you buy one or which one you buy. I get no money from any of them, although it is a very lucrative market if you find yourself in the possession of one of these patents, as we'll talk about later. All right, for starters, does anybody know who this guy is? Let me see if I can pull up the chat. Bonus points for anyone who does. You get 10 seconds. This will be a slightly interactive Grand Rounds as well. It's more fun that way. All right, I'm going to guess no. So this is Dr. I don't know that I can pronounce his name, Taku Ogoye. This is the gentleman who really made pulse oximetry a viable technology. And I think it's appropriate to pay homage to him because he did a really neat job. And the next slide, so what we're going to talk about with pulse oximetry is something that I really underappreciated. And I think we all, as medical students, or even before, we learn about how the pulse ox is amazing, and there's this little red light, and it shines, and your blood absorbs some of the light, and then that's how we measure pulse ox. And that's well and good, and I think that's an appropriate starting point. But I think for clinicians, we need to have a deeper understanding of how this technology works, because while it is a very valuable technology, and Dr. Ogoki, I don't know how to say his name, I'm sorry, he was so proud of his work, and I believe he won the largest award in electrical engineering, if I'm not mistaken, for this technology. But as clinicians, we need to be very familiar with the reasons why it can go wrong and when it is not presenting the information that we need, because it is so ubiquitous in our clinical assessments. And so many times, as we'll get to later on, our judgments that we're making in terms of treatment plans are oftentimes actually based on this technology. So the point I want to make most with this slide is I want to talk about the reason why it's called pulse oximetry and not just oximetry. The reason for that is it all centers around pulse, because if you think about it, you have both arterial and venous supply everywhere. When you're doing an art stick, you know it was artery. If you're doing a venous stick, you know it was venous. But in this case, you're just sampling all of the blood of the tissue over which the sensor and the light emitting diode are present. So how do we differentiate the difference between arterial and venous supply? Well, then this is what Dr. CCategory came up with. So what you see, so we've got part A here of the slide. And by the way, I forgot to mention at the start. So all of these slides, my presentation should be available, and the references will be found in the notes for each of these slides. And part A here, so it says the relative volumes of the non-pulsatile and pulsatile tissue components. So what you have is you have AC and DC. The AC is the change in the arterial blood throughout the systole and diastole cycle. And then you have the DC, or the continual current, and that is venous and capillary blood and the stationary tissues. Interestingly, this mirrors AC and DC current for electricity. Oh, I'm sorry, that we are all familiar with. In part B here, you can see how there's an increase in arterial size there, not of the actually capillary beds themselves, but in terms of the signal processing that's available. And so you've got the change in red and infrared light absorption. So you've got the two different light emitting diodes that are looking at these two different wavelengths. And then in part C there, you can see how this is the equation that is used to create the standard curve. So you, based off of the changes in systole and diastole. Exactly how this works is not as important, but what is important is focusing on the pulse, because as we're going to get to when we talk about some of the ways in which these things can go wrong, that pulsatile flow is going to be extremely important. All right, so let's talk about why pulse oxes go bad. And there's a lot of things here. Most of them you're familiar with, and we'll focus in detail on a couple of them. So causes of intermittent dropout or inability to read the SpO2. So obviously, if you're not having good blood flow to a certain area, you're not going to be able to check the pulse ox very easily. This happens pretty regularly in pediatrics. You have kids who are doing peripheral vasoconstriction, or maybe they're hypovolemic and shock. Oftentimes, we want to put these, and it's best practice to put the pulse ox sensor on the spots that have the greatest capillary beds, the fingertips, the edges of the ears. These are also the first thing that go in terms of peripheral vasoconstriction. So you need to keep that in mind when you're doing that. Now, how does this cause the SpO2 to not work? Well, there's two things that we're going to look at in terms of signal processing with these. One is there needs to be a high quality signal, which means just like when you're on the phone and you go over a bit mountain and you lose that signal, the SpO2 can lose that signal as well if the light is not penetrating the tissues well, or if there's nothing for it to pick up. That's problem one. Problem number two is if there's any change in this systole and diastole, and if that is confusing in some way, you can still have a great signal, but you can have an errant reading based off of that mess up as well. So I know a lot of times we go to the monitor and we look at, first of all, is there a good waveform? Great. That's us trying to assess, some of aspect of the systole and diastole phase, and that's why we were trained to do that. The other aspect is on the right side of the monitor. Beside the SpO2, at least on the inpatient units, there's a star value, and the outpatient units have a way of representing this as well. 3 stars means a high quality signal. So even if you have pulsatile flow with a poor signal, you can have issues and vice versa. So we're going to number 2, causes of a falsely normal or elevated SpO2, carbon monoxide poisoning, and sickle cell anemia vaso-occlusive crises. This gets at kind of the oxygen hemoglobin binding capacity of the tissues and ways that might be altered. I think we're all familiar with that. Causes of falsely low SpO2. This is a big one for us, the venous pulsations. So what ends up happening in this is you have a kid who's moving around, maybe even not all that much. And as a process of them moving at their, whatever hertz these 2-year-olds are flying around the room at, what they're doing is they're creating a pulsatile venous flow. This makes it extremely difficult for the SpO2 monitors, which are so focused on what is that change in the arterial flow, that then they begin to pick up the venous flow as a part of the arterial flow. So that's sometimes why you can actually have, and I think this is one of the most critical points, you can have an excellent waveform, you can have excellent signal, and still have a falsely low SpO2 because the machine doesn't recognize that it's picking up venous pulsations, which is something that we see pretty regularly. So the excessive movement is tied with those venous pulsations, which is the next one. Although that excessive movement can also cause poor signal, and it can also obviously mess up the arterial pulsations as well. Pigmented dyes, inherited forms of abnormal hemoglobin, fingernail polish, that's focusing on signal attenuation loss, severe anemia, obviously you're not going to be able to pick up if there's no hemoglobin there. So causes of a falsely low or high SpO2, methaglobin anemia, self-hemoglobin anemia, poor probe positioning, sepsis, and septic shock. I think we're all familiar with those. And then causes of a falsely low, as measured by a co-oximeter, severe hyperbilly and fetal hemoglobin. So the next question is, so we have pulse ox. Well, what's actually normal? And I think this is a fascinating slide for us to focus on because no one knows. So there, and again, you can see the references here. In one of the papers that I read, they found that for most clinicians, the point at which they were confidently able to discriminate someone as exhibiting cyanosis was around 85% saturation. Obviously, this is much lower than the point at which we would oftentimes change our intervention strategies on an inpatient unit based off of pulse oximetry. So what that's getting at is that we may not be great at assessing cyanosis, assessing hypoxemia at the saturations that we are interested in. So let's go to the different institutions that manage some of these things and give recommendations and see what they say. Well, the WHO says if you're in a resource poor area, 90 or above is normal. If you have lots of resources, 92 or above is normal. The CDC says, well, let's make it 95. The AP says, absolutely not, let's make it 90. No one really knows. And the reason is there's not good outcomes data to say at this saturation, these bad things happen or these good things happen. So in the upper right there, you can see this is our normal hemoglobin desaturation curve. We're all familiar with this at medical school. You can see that at the 90% saturation there, it equates to a PaO2 of about 60 in millimeters of mercury. And then what this is referencing is you can see that just past that 90 point, the slope of the curve becomes more significant. So the reason why all of these institutions are focusing around that 90% mark is because they're trying to get to the point where we would provide an intervention before we reach this critical slope change of the graph. So, but again, we don't really know. So what data is there to say what's normal for healthy human beings? So down here at the bottom, we have table 1, descriptive statistics of O2 sats. And by the way, there's a lot of literature out here on this. Not all of it's great and helpful, but I'm only including just a small sample of that. So what's helpful for us is let's look at this, which looks at over a nighttime, what is the lowest period of saturation for otherwise healthy children? So this study excluded all the sick kids and tried to look at, for various ages, what is the lowest saturation. So the low sat is the lowest that they went to. The low sat 10 is they spent 10% of their time below that. And then the sat 50 is they spent 50% of their time below that. What's fascinating is that if you look at this, for the less than 1, the low sat is really at 90, and these are for healthy children. So it's very normal that for kids to desaturate to 90, and of course there's some standard deviation there of in the 2 to 3 range. So a good percentage of kids are dropping actually below 90, healthy children, while they're asleep. And so I think that just raises questions for it just emphasizes the importance of when you are using pulse oximetry as a part of a clinical scenario, it should never be used in isolation. Your healthy kid who was there one night and happened to desat to 89 for a few seconds and then come back up does not need interventions, although we do sometimes give those interventions, whereas a kid who's maybe sustained at 90 would be something different. All right, so what do we do? So we don't know what a normal saturation should be, but we're going to have to make clinical decisions based off this anyways. This is not a dig at our emergency medicine colleagues right here. What this is I want to show how the confusion around normal pulse oximetry ends up creating clinical scenarios that are challenging to deal with. So in this study, bronchiolitis management preferences and the influence of pulse oximetry on the respiratory rate decision to admit. So what they did is they created a clinical vignette that I'll summarize. Basically, you have a kid who's a bronchiolytic. He's retracting a little bit. He overall looks okay, but he's in the ED and he's got a pulse ox on. So in one scenario, he has a pulse ox of 94, and in the next scenario, he has a pulse ox of 92. They asked a bunch of ED docs, would you admit the patient? Would you treat the patient with a bronchodilator? Would you give inhaled albuterol? And would you give inhaled epi? So let's look first here. So for an SpO2 of 94%, 43% of the docs would admit that patient. What's fascinating, though, is if the SpO dropped only 2 points to 92, that increases from 43 to 83%. So you have a doubling of the admission rate with a 2% change in pulse oximetry, with no change in patient clinical status, no variance between the two. And both of these numbers are above the AAP recommendations in terms of pulse oximetry. So just fascinating. And this can create confusing clinical scenarios for patients where the ED tells them that their pulse ox is low and that they need admission. They go to see their pediatrician or they're admitted to the floor, and then we are not putting them on oxygen, and their pulse ox may even be lower than they were in the emergency department. So this understandably creates some confusion for parents. So, and then we see here, hypoxemia is common in children with lower respiratory, and the SpO2 is frequently below 94%, at least in around 75% of the children under a year of age admitted with acute bronchiolitis. So this is something I know we all encounter very frequently, although albeit not as much this year in coronavirus, but certainly not an uncommon scenario for us. So let's talk a little bit more about bronchiolitis, because this is one of the scenarios where this technology is most used. So now we've got a kid in the hospital. What do we want to do with this pulse oximetry? Well, there's a good amount of data. It is relatively suggestive that pulse oximetry may not be super helpful in terms of deciding management strategies. So we've got two here: impact of pulse oximetry and oxygen therapy on length of stay and bronchiolitis admissions. I've tried to underline some of the salient points here. So the hospitalization was prolonged because of oxygen concerns, which showed up on pulse oximetry, and the length of stay was prolonged by an average of 1.6 days. This study also showed that overall health outcomes were not really changed. So your health outcomes were about the same. You had an increase in length of stay. Then we look at the next study, oxygen saturation targets in infants with bronchiolitis, a BID study. They were also looking at what SpO2 we should start to provide interventions, and they found that 90% or higher is as safe and clinically effective as one is 94% or higher. So this kind of supports that AAP guideline of around 90%, which is something that we use in practice pretty frequently here. Although, again, other groups of medicine are using different values. All right, we're going to switch gears here. We've talked about pulse oximetry technology. We're going to have a quick history lesson. I'm going to pull up the chat again. Can anybody tell me what this is? Obviously, it's a table. You don't get points for that. More specifically, can you tell me who created or designed this table? Thank you, Dr. Nelson. It is. It doesn't have to be in the living room, though, so you don't get points for that. All right, we'll keep going. Well, it will become relevant, I promise. Who is this guy? Somebody ought to get this one. Thank you, Hannah Smith. This is Lindbergh, so the famous aviator. But what happened to his kid? Does anybody know? It was kidnapped. Thank you, Janie. That's exactly right. So this is the famous case of the Lindbergh kidnapping. It's an extremely sad story if you go and read the official FBI. But essentially what happened was there was a man who was looking for ransom. As far as we know, he didn't know that it was Charles Lindbergh in particular. He created a ladder, climbed up, stole the infant out of the crib while mom was in the shower, ran away. Mom comes out, sees the baby's gone, calls the police. They spent, I believe, it was more than a year with multiple ransom notes trying to figure things out, and the child was eventually found partially decomposed in a ditch a little bit outside of town. This is obviously an extremely distressing story, as it was to the CEO of the Zenith Radio company who had young children at the time. So he wanted to find a way to monitor his children and to hear so his kids were not kidnapped like the Lindbergh baby was. So he hired, and this is a reference back to the table, someone named Isamu Nochi, who later in the 70s would create that iconic table that I think a lot of us recognize, to design what was called the Zenith Radio Nurse. So you can see it pictured here. That is actually the receiver, the receiver part is that you see there. It was actually heralded as kind of an amazing design at the time, not technologically, but also just in terms of its aesthetics. And then there's that kind of much uglier one that went in the room with your baby. And so what happened is obviously your baby would cry. It was a one-way audio monitor. You can be here, having a dinner party with your friends, drinking whiskey and playing cards, hear your baby cry, and know that you should respond to them. What's interesting, though, is this product really didn't stay on the market for terribly long, and unfortunately, it was not very popular because at that time, wireless radio transmission was just in its infancy, and this thing would pick up every radio station known to man in the area. And so you'd be trying to listen to your baby, and you'd be listening to whatever radio station was happening down the road. So obviously, that really impaired its ability to be successful as a baby monitor. So it didn't last for very long, but this is kind of considered the grandfather, if you will, of baby monitors. So next, not a lot happened to baby monitors for a while. One of the next big things we're going to focus on, we're kind of going forward a little history and too much, is detecting body movements. This was kind of the next big change in what baby monitors could do, and this happened in the 1970s as a part of kind of an increased awareness and concern that SIDS may be related to apnea and bradycardia events. We'll come back to this later, but here's the original patent for that baby monitor, or the baby breathing monitor, which was patented in 1981. We're going to go back in time a little bit, though, to World War II for the next development in the audio monitor. Obviously, this is a torpedo. Does anyone know why World War II torpedoes might be related to baby monitors? All right, I'll take that silence as a no. It is an obscure connection. So we talked about the Zenith radio nurse and how signal lock was an incredible problem for this monitor. That technology changed in the 1940s with the advent of torpedoes. Obviously, you don't want your torpedoes locking onto every radio station known to man and missing their target. So something called variable frequency hopping technology was created so that the Allies could use radio frequencies to guide their torpedoes. This allows baby monitors and torpedoes to hop to various frequencies to find the signal that is stronger and to be able to change mid-flight or mid-baby transmission to a new frequency if necessary in order to maintain that signal lock. So next we have kind of in the 90s, all of a sudden these monitors start to flourish. I certainly had one of these Fisher-Price baby monitors. You guys probably recognize them. You get to go and paint your chair and do everything while your baby sleeps soundly in the next room. If only that's how parenting went. This is the first baby monitor made by a company by Summer. First video baby monitor. As you can see, it's got at least 3 pixels in the screen there. It was all black and white, and it was one of those big CRRT monitors. So good luck lugging that around. But this was kind of the next development there, and that also happened kind of in the 90s, although video baby monitors did not take off for a while until recently. And then now, of course, you can video anything you want, and the majority of the monitors are actually video as opposed to audio. So next, let's take a look at kind of all the monitors available to us. There's a lot of multi-monitors. Obviously, my talk is most focused on pulse oximetry. As you'll see, there's only 2, but really 1 pulse oximeter that remains on the market. That's the Owlet in the bottom left-hand corner. The Baby O2, Amazon has a litany of these little pulse oxes that you can attach to something, and that's one of those. It's not a true baby breathing monitor like the pulse ox is, but I included that to say that there's a lot of kind of random little pulse ox devices out there. There's a whole lot of other devices. So we've got the Baby Sense 5, the Snooze a Hero, Sense U, Angel Care. All of these use different technologies to monitor baby breathing. And they really focus on 2 different things. There is a movement sensor. So you may have, and this is how the Snooze a Hero works, and amongst others. So you might have a clip that goes on the diaper. You might have a sensor that docks on a little spot on the onesie. You may have, any number of different spots where this sensor is placed, and it detects via accelerometer changes in the, the baby's chest, the movements of the baby's chest, and therefore, if you have cessation of that, the baby must not be breathing. Another generation of baby monitors uses artificial intelligence and video tracking to do that. So you see the Nanit Pro in the bottom right-hand corner. You actually wrap your baby kind of in this wrap that has a bunch of black and white shapes on it. The camera is watching the movement of those shapes and analyzing their movements in order to determine if the baby is moving or not. That technology also applies to different things, including if your baby has a blanket over their head. A lot of these have facial recognition software and can alert you to that. They can alert you. Some of them, if your baby is a little older, like maybe toddler age and is trying to crawl out of the crib, it'll alert you that they are near a danger zone. There's a lot of different ways in which this technology is applied. I also want to just let you know that SpO2 devices are everywhere. So your iPhone can measure SpO2. FYI, I'm not covering the literature for this, but it's a horrendous measure of SpO2, so don't use it. The iWatch has the ability to measure pulse ox, as does the Galaxy Watch and Fitbits. Now, this is not available in every nation and in every principality because it's based off of local regulations. Which brings me to, are these things regulated by the FDA? And the answer is complicated. Sort of yes, and sort of no. And so we'll get back to that in just a second. And so then let's talk about kind of the future baby monitors. So these are one that is soon to be on the market, or is on the market, one that may come soon. So on the right, we have the Lumi. This is a baby monitor. It is the movement type. So it goes on the diaper. It senses that your baby's moving around. But because they partnered with Pampers, it also goes over the wetness indicator. So the moment your newborn baby pees, which happens about 3,000 times a day, it seems like, you receive an alert to your phone. Congratulations, your infant has urinated. Obviously, Pampers loves this because they sell a lot more diapers that way. But if you weren't notified enough that your baby's heart rate is beating, that they're breathing a lot of times per minute, most of the baby monitors alert you when the baby moves or rolls over. So that's a lot. Now you can also be alerted that your baby pees. If that wasn't enough, what's a little scary on the left is a Google patent that was recently filed. And I put the actual kind of verbiage there. You can see it's obviously just in patent form, so there's kind of that little schematic there. But it has the ability to output to a caregiver based on the determined non-auditory discomfort state. So what this technology does is a camera is actually tracking the distension of the eyelid by the pupil underneath, and is looking and is monitoring your baby's eye motion tracking with the intent of letting you know that your baby hasn't cried yet, but that they're really uncomfortable and that they might cry soon. So since your crying infant, wasn't bothering you enough, we should alert you that your infant may cry in the near future. There's a little bit of sarcasm in this talk too. Obviously, these technologies can be very useful when applied in a certain situation. But we'll get to how, maybe this technology can be a little bit too much for a lot of situations. So let's go back and revisit that FDA piece that we talked about a minute ago. So related to the FDA, there's a couple things here. So one, pulse oximetry, when it makes health claims, is regulated by the FDA. It's considered a Class 2 device. However, if you don't make a health claim with the device, you can put it under the wellness category. So it fits in apparently more with yoga than it does with a true medical device when you phrase it that way. So all of these commercial monitors are claiming that these pulse oximetries are used for wellness as opposed to health. And therefore, we'll see in their marketing, they cannot then make specific claims about health claims about what these monitors do and don't do and prevent and don't prevent. So let's talk about, so because they're not FDA regulated, that means that they have much lower standards that they have to achieve in terms of their reliability and their performance. Now, that doesn't mean that all of them perform poorly. It just means that they're not regulated to the same extent. So I use this slide to show you that. So we've got this is talking about inter-monitor variation. So what we have here too is we have a Misimo Radical 7, which is a commercial grade pulse ox we have that technology available pretty regularly. They use that as the standard and measured against that 2 baby monitors that were pulse ox, the Owlet Smart Sock 2, and then also the Baby Vita. What I want to show you here is, so on the left is the Owlet Smart Sock, on the right is the Baby Vita. Let's look at their sensitivity and specificity. So for monitor A, the Owlet Smart Sock, for monitor A, sensitivity and specificity. So we're looking at like 88% for that, and we're also looking at bradycardia, so 88 and 85 for hypoxemia and bradycardia respectively. That's pretty good. There, and so if we look kind of at the dots here, you've got your standard slope there. You can see that only a few of the observations from the Owlet are falling into the false positive or the false negative range. It actually does quite well with true negatives and true positives. Compare that to the baby Vita, which is the right graph there. Look at how the baby Vita found 0 true positive events. It also didn't find any false positive events on the bright side if you can't identify any true ones. And so this monitor was incredibly unreliable. What's interesting, though, is it sold for more than the Owlet when it was on the market. It's not on the market anymore. So I use this slide to show you that you really have to be careful. Just because these monitors are priced very high and just because they make certain claims and have certain technologies does not mean that technology is actually functioning appropriately. So if you're counseling your patients on these, you may want to advise them to do some homework if they're able to figure out which one of these monitors is actually performing in the way in which they think it might be performing. So next, let's focus on, so what do we as pediatricians do with this information? So it all comes down, and this is the AAP policy statement on apnea, sudden infant death syndrome, and home monitoring. So where did all of this come from? Well, like we mentioned, in the 1980s, we looked at that patent that showed that there's baby breathing, that patent for the baby breathing technology. Well, why was that such a big deal? Well, that's because in the 1970s, there was a case study. The 2 infants were admitted to the hospital. They had previously had 3 siblings who died at home suddenly. Those 2 infants were known to have apnea events while they were in the hospital. They were discharged shortly afterwards, and both died suddenly and without cause. So based off of this, the academic community said, well, we had these 3 kids who died of SIDS. We had 2 kids who were in the hospital with clear apneas. They went home and also died. There must be a pretty substantial link between apnea and SIDS, which intellectually is not a difficult jump to make. Unfortunately, what has come out later is that all 5 of those infants who died in the 1970s were all products of infanticide. And it is presumed that none of them actually died related to apnea or bradycardia events. So, but we didn't know that at the time. And so this kind of launched pediatricians in general, and certainly the market, to look at ways to identify apnea and bradycardia so as to prevent SIDS. Then, after the infanticide aspect came out and the literature and the data was shown, the link is not as clear as it may seem to be on first guess. So let's look at what the AAP policy statement, which is really what we're going to base at this current time our management outpatient decisions and inpatient to a certain extent on. So it's a wordy slide. I've underlined the most important parts because I think focusing on the actual verbiage is helpful for us. So let's look at a couple things. One, and I'll start in the upper left and work to my way to the right. Apnea is not predictive or precursor to SIDS. We'll get to more why they make that claim. Second, furthermore, apnea appears to resolve at a postnatal age before which most SIDS deaths occur. So if we look back at their numbers there, SIDS tends to happen at around like 45 weeks or so later on, or 52 weeks for term infants. What we'll see is there's a good study to show that apnea actually resolves prior to that, which kind of breaks that causal link to a certain extent between the apneas and SIDS. So we do know that infant sleep positioning and environment, smoking in the household, and death scene investigation to exclude infanticide are significant factors in our understanding of SIDS. The AP then goes on to say, none of the current, and then, so as a kind of an aside, none of the current monitors available for home use detect obstructive apnea as reliable. That's because pulse oximetry doesn't always change super quickly. You really also want to look at the actual movement of the chest wall. That may change as some of the monitors improve that technology, but when this policy statement came out, that was not the case. So next, the hypothesis that apnea is the pathophysiologic precursor to SIDS was proposed in 1972. This is that part we've already talked about where the infants died of infanticide. Next, given the lack of evidence that home cardiorespiratory monitoring has any impact on SIDS, prevention of SIDS is not an acceptable indication for home cardiorespiratory monitoring. They then go on to say that there are some things that may be indicators for it, and we'll talk about those as well. And then finally, current evidence suggests that if such monitoring is elected, it usually may be discontinued after 43 weeks post-menstrual age, which is the time which the study we're about to go over found that apneas tend to resolve by. So let's look at so the AAP policy statement does, though, say that there are some acceptable indications for monitoring. The first, infants who've experienced an ALTI or an apparent life-threatening event. I think this is fascinating and perhaps a little bit inconsistent, because a lot of times these, kind of pseudo apnea or brady events present as alties. And so we're saying that, monitoring is not acceptable for the prevention of SIDS, but it may be acceptable if we have alties, which typically we don't do much workup for anyway. So I think that there's some kind of confusion related to this, and I could see, and I personally have a hard time really knowing what to make of this one. Second, infants with tracheostomies or anatomic abnormalities that make them vulnerable to airway compromise. That's a given. Infants with neurologic or metabolic disorders affecting respiratory control. That also makes sense. 4, infants with chronic lung disease, especially those requiring supplemental oxygen, continuous positive airway pressure, or mechanical ventilation. That obviously seems like a gimme. Now, the AAP is recommending that we use the hospital-grade monitors. These acceptable indications do not then mean that your patient should go out and buy one of the consumer-grade models in order to do that monitoring. While some of them do approximate and actually quite well track with some of the hospital-grade devices, they are obviously not as good, and there is, as we looked at earlier, a huge inter-monitor variation, and some of them are horrendously bad at monitoring this. So next, let's look at the cardiorespiratory events recorded on home monitors. This is called the Chime study. This is kind of the cornerstone of that AAP policy recommendation, where they look at kind of breaking that logical connection between SIDS and apnea events. So I'll kind of summarize some of the words on this slide. So based on 700,000 of events, they determined that pathologic events are actually quite common, even in healthy term infants. So they're looking at times when babies had apneas and bradycardias, and did that affect their health. So they determined that these pathologic events, like true apneas or bradies, if you monitor all the babies all the time, are actually quite common, which then begs the question, well, what do we do with that information if we're recording it? Second, so our data indicate at least one extreme event only in preterm infants, and only until about 43 weeks of post-conception age. So this study looked at differences between extreme events and pathologic events. And I'm happy to provide this study for those of you who want to go into it in depth. But they found that those extreme events were obviously in preterm infants, and only until about 43 weeks PCA, which is then where you see the AAP policy statement come in and talk about kind of breaking that logical connection. So, and then we see here on the side, they're testing the hypothesis that preterm infants, SIDS, and infants who have experienced an idiopathic ALT have a greater risk for cardiorespiratory events than healthy infants, and that's related to post-conception age. So that's what they're getting at here. So then if we go on to, let's look at the differences between the Chime study and the AAP policy statement. Because that obviously the policy statement is really leveraging the Chime study. And if you go and read their policy statement, there's a pretty good chunk of it that is kind of summarizing and going through the Chime study. The Chime study says in the paper itself that, quote, the Chime study was not designed to address the important question of whether infants who experience extreme cardiorespiratory events are more likely to die of SIDS. These differences in timing suggest that extreme events are not likely to be an immediate precursor to SIDS, although it does not eliminate the possibility that they are markers of vulnerability. And they said the observation that 20% of asymptomatic preterm infants experience one extreme event highlights the need to determine the clinical relevance of these extreme events. And until then, it is not possible to refute or support the recommendations of the NIH consistent statement that monitoring or an alternative therapy is medically indicated for symptomatic but not asymptomatic preterm infants. Basically, what the Chime study is saying is we wanted to look at how these extreme events are related to, infant outcomes, but we're not really looking at, trying to figure out these home monitors and whether or not they prevent or don't prevent SIDS. The AAP policy statement, I think, doesn't make unreasonable bounds from the Chime study, which, although that was not their goal of the study, they certainly are looking in that same neighborhood. But the AAP goes a little bit farther to make some claims based off the Chime study that the Chime study doesn't claim themselves. So if you look at the policy statement, events exceeding the extreme threshold occurred in 10% of all infants and 2.3% of healthy term infants. The only groups of an increased risk compared to healthy infants were those in the preterm infant, the 43 weeks post-menstrual age. We see that number come back again. Then the AAP policy statement says these results indicate that cardiorespiratory monitoring for apnea and bradycardia is not an effective tool to identify infants at great risk for SIDS, which is a jump from the Time study. This study documents that many infants experience apnea and bradycardia, exceed current conventional alarm thresholds, and do not die. I think that is something that the Chime study talked about, and an important thing. When you're monitoring these infants, one, the monitors can go off at times where there's truly nothing wrong. But sometimes, and frequently, they actually go off and identify true events. The issue is that these events don't really relate to overall health outcomes, but can cause an increase in medical utilization. So let's look at how these baby monitors are marketed to people, because this is how, so we talked about how we are interacting with the monitors. Let's talk about how our parents are interacting with the monitors. So top left, it's all about alleviating fears and helping you as a parent know that everything about your child is going well, and being able to predict before your child ever gets sick that they're going to get sick. So a lot of them say you get better sleep. Well, I find that a little ironic, because if you look in the upper left-hand corner, you see that mom is very much not asleep, but is instead watching her baby on the monitor on the phone. I kind of show that, say these monitors can be rather anxiety-inducing, actually. So let's look at some of the health claims that these infants, that these monitors can, but try to almost not sort of kind of make. So we see the outlet CEO down in the bottom right. We can't promise to prevent sudden infant death syndrome, or SIDS, right now, but we believe notifying parents when something wrong maybe can help. They're really brushing up against making claims there. Let's look at, Cubo AI, which is one that looks at baby movements using camera technology. If you look at their web URL, it's https://cubo.com/pages/save babies lives, ####. And in an article at the Washington Post, their chief strategy officer said that fear is the quickest way to get people's attention. So Baby Vita, the monitor that we referenced earlier that was so different than the outlet, and Baby Vita actually was quite terrible in terms of appropriately diagnosing changes in pulse oximetry. It's no longer on the market, but it's reported, and you can find this in several articles, that their tagline was, "What is the sound your baby makes if he or she stops breathing?" which is obviously extremely anxiety producing. Then if you go on the outlet website and you look at their clinical vignettes and their parent stories, what you find is that most of these stories center around a mom who had a child who appeared fine, was maybe a little bit sick, but the mom felt that the child was fine. They take them to the hospital, and all of a sudden the doctors freak out because the child is really sick and they need immediate medical attention. Kind of underpinning and kind of trying to show parents that you lack the ability to know if your child is sick or not. You need our monitor to tell you that, and our monitor does a good job of that. So if you look in the top, you can see, I finally decided to take him to the hospital thinking it was probably nothing. At the hospital, they found that his oxygen levels were low, as the smart sock had indicated to me. And he was immediately put on oxygen and taken to the ICU. He was diagnosed with bronchiolitis, which is similar to RSV. He had no fever. His mood was amazing. He was eating and sleeping great. I had no idea something was wrong. This might have potentially saved my baby's life, and this is the only thing you need for your baby. My son is here today to prove that. And that was pulled directly from their website. So obviously, these are really using parents' fear. So I took a little rabbit trail one day and tried to find some of the psych literature on fear. I found a massive 60-some page document on summarizing fear and appealing to fear, a meta-analysis of fear, appeal, effectiveness, and theories. And they looked at, so if you're going to make a fear appeal to someone, how do you do it and really make it stick? Here's what they found and summarized at the end. Specifically, fear appeals are particularly effective when they communicate depicts relatively high amounts of fear, includes an efficacy message, stresses severity and susceptibility, recommends one-time only behaviors, and targets audience that include a larger percentage of female recipients. If you look at the marketing strategies for these baby monitors, they check every single one of those boxes, which is why the yearly market is $1.2 billion for these baby monitors. Now, I do want to go back one time because I don't want to be disingenuous here. I'm obviously making a very strong claim that these baby monitors are leveraging parents' fears in order to sell products, and they are certainly doing that. What I would be remiss to acknowledge is that there is very real fears associated with parenthood. Kids do die, and we need to find a way to communicate that to parents and interact with them on that very scary realization. SIDS is a real thing, and I in no way want to kind of undermine that that happens to people, and that it is absolutely horrendous when it occurs, and that if there's something that we can do to prevent that, or better alleviate that, we by all means should be looking into that. And so we have to find a way to both acknowledge the reality that these monitors are unfairly leveraging that fear, but at the same time acknowledge that parents are appropriately concerned about these things. And even myself as a parent, worries about these things sometimes when you're laying in bed at night with your kid, even though I'm a pediatrician and I know a lot of the data. So I just want to make that caveat there that life is scary, and we need to find ways to be able to acknowledge that as well. So, what presentation isn't complete without a little quote? So there is no illusion greater than fear. I think this is helpful because what these fear tactics are doing is they're creating this illusion where a parent is not really fit to take care of their child or to be able to know when they're sick. And that illusion drives people to make irrational decisions. So I want to take, with the last couple minutes of the presentation, a little turn and talk about some things related to these baby monitors that don't come out very much. And first is that the technology associated with them can be a pretty significant security threat. So Rapid7 is a research group that looks at technology vulnerabilities, and they found that baby monitors are extremely vulnerable to hacking. This plays out in a couple ways. One, hackers are frequently using these video systems to, because they're in rooms where moms are nursing and things, watch for kind of illicit material. They're using these cameras in order to kind of surveil a home to see if there are any valuables there, or they can use it because these are all internet-driven monitors. They can use them as backdoor credentials to then gain access to other technology items in the home that may have more valuable financial or other data. So you've got Todd Beersley there from Rapid7's Director of Research with a couple quotes. Quote, we found that they were pretty much across the board, we found that they were pretty much across the board, some pretty easy to exploit vulnerabilities that have already been solved in other computing realms. Baby monitors might, for instance, reset to factory defaults without warning. You can bypass some of their authentication. And he says basically they're missing the safeguards built into most modern systems. And then there's an NPR article of a mom who had one of these video baby monitors get hacked, and it kind of goes through her story there. You can see that one of the technology consultants said that hackers that I know of and hang out with refer to the Internet of Things, which are these devices that are not pure computers, such as like your doorbells that have video monitors or video baby monitors. Those all fall into the Internet of Things. So hacking those things is like hacking on easy mode or hacking like it's 1998. I don't know that this is something you need to talk about with your patients, in your 15-minute well child check, but I think it's important that we recognize that this technology has some inherent vulnerabilities that are not currently being addressed that can actually put infants and families at risk. And then finally, we'll finish with a little bit of philosophy. This is the idea of transhumanism, with Francis Fukuyama saying the world's most dangerous idea. So why is this the case, and what is transhumanism? Well, and bear with me, some of you may know transhumanism through people like Elon Musk. And transhumanism, and I've got the definition here, it's a little bit difficult to nail down, but it's a blanket term given to the school of thought that refuses to accept the traditional human limitations such as death, disease, and other biological frailties. So the idea, roughly, is that mankind has kind of reached the peak of its evolution potential, and the next big step in evolution is our assimilation with machines. You can get kind of the crazy stories you read online of people who are freezing their grandmothers to maybe bring them back to life one day or download their brains. And it's kind of easy to create this straw man for transhumanism that we can easily destroy and tear down with some of these kind of crazy, far out sci-fi sort of stories. But if you look at the real definition of transhumanism, it's the idea that we refuse to accept the traditional human limitations such as death, disease, and other biological frailties. That sentence actually aligns relatively closely with some of the tenets of medicine, which we are also pushing back against death, disease, and other biological frailties. So I think that we can easily be subverted into this idea that we can overuse technology to fix some of these things like death that have plagued mankind for forever, and that we can be subverted into thinking that this XYZ technology solution can fix that. And how can we subvert these biological frailties? And I think it's important to think about how this applies to a lot of things like ADHD, maximizing IQs, orthopedic implants, cosmetic surgeries, other sorts of monitoring. We have to keep these things in mind. I've got that figure 4 on the left, which is, if you remember that Google patent that was monitoring babies' eye movements to say when they may become distressed soon. That is from that. And it shows that your entire house is connected there. This is from the baby monitor patent. You can see that your HVAC is connected, your pool heater is connected, your irrigation system is connected, and your baby is just one of those connections in one of these rooms. So it's already starting to edge on some of these claims where humanity is just kind of assimilated as a part of kind of your home system. So we just have to be careful with thinking this way. So what are the risks of this? Well, as we incorporate technology into our lives more and more, we need to recognize that technology is expensive and always has been expensive. When you look at baby monitors, that Zenith Radio Nurse, when it came out, scaled to today's dollars, cost $500 in 1938 relative to their income at the time, which is the same that the modern baby video monitors cost. So all of these monitoring systems have always been about the same percentage of people's incomes. Who can afford that? Only the rich. And so technology has nearly always been implemented as a means of oppression first, and tends to make divides between rich and poor, neurotypical and not. It tends to create and worsen those divides as opposed to heal them. Not that that's always true, but that is a risk of technology. And then second, this theory presumes that certain people know what good is. There's going to be somebody at the top driving this technology. We've got a lot of technological CEOs today who are in this driver's seat. And that these people recognize what good is, and that they will be the arbiters and stewards of these decisions and decide where this technology that drives our life goes. Now, if you love Aristotle and the idea of a benevolent dictator, this is not necessarily too crazy of an idea, but we just need to be careful when we recognize that when we give our lives away to more and more technology, someone has designed that technology, and that someone is doing it in a way that has not only physical ideas, but also more philosophical ideas associated with them as well. And we need to be careful that all of the reasons that technology is being implemented, we agree with when we implement it in our own lives, as opposed to just kind of blindly accepting some of this technology. So again, this has been a relatively strong critique in baby movement monitors in some ways. I in no way want to suggest that these monitors are useless, that certain parents find them very helpful, that they even alleviate anxiety for certain parents. What I hope to show from this presentation is that these baby monitors have some concerns that we need to be aware of as pediatricians, and that a vast majority, or excuse me, a substantial amount of your patients, perhaps not the majority, are either purchasing or seriously considering purchasing these devices, and we need to be able to kind of better understand how they work so that we can interact with our patients on them. So key points. Pulse oximetry relies on the pulse. The main factor is errors, but we need to look at the other risk factors as well. There's no consensus on what a normal oxygen saturation should be. Baby monitors have been around since the 1930s, and they will continue to be very prevalent. Baby monitors companies use fear-based tactics to drive business, and the job of the pediatrician is to appropriately identify risk factors that might warrant monitoring versus providing reassurance to anxious parents. This gets at, we can use hospital-grade monitoring at home if necessary, and we need to know the indications for that. Most consumer pulse ox technology is not FDA regulated or approved, and there's great intermonitor variation. Infant monitoring has not been shown to decrease the prevalence of SIDS, but things like safe sleep, smoking, and these other things we should absolutely counsel patients on because they have been very explicitly linked. The AAP does not recommend infant monitoring for SIDS prevention. Baby monitors are easily hacked and can pose a threat to network security and human security. And we need to keep in mind how to best implement our technology, as advances have historically been harmful as well as helpful. So I've got a couple questions, and then I'll leave a minute or two for some questions from you guys. I'm sorry that I'm potentially going to go a little long here. So what is the saturation at which most clinicians recognize hypoxemia? You guys can put in the chat or talk. I'll give you a couple seconds. These are mostly softball questions. I'll take the silence in the chat as 85%, in which case you are all right. Good job. According to the Chime study, what is the approximate post-conception age at which extreme apnea and Brady events are likely to have resolved? 43 weeks. Thank you, Janie. Perfect, everybody. And then last but not least, should I advise my family to get a consumer-grade home monitoring system? I appreciate the note, Dr. Parmeshwar. I'm actually going to go with probably not. So again, every situation is individualized. I think I've made a relatively hard case against them, and I want to be careful that I don't overdo it. I've tried to make the appropriate caveats here. These systems can be helpful for certain people, but we need to be able to, the movement in society is towards these monitors, and so I wanted to provide hopefully a healthy dose of skepticism, and I think in general we shouldn't be advising them, but I could certainly foresee certain situations where they might be helpful. So thank you. As again, references are in the notes section attached to the presentation slides, and because I'm a nerd, I've also included thank you as Morse code and as hexadecimal. So it says thank you 3 times. I appreciate you all joining me today and listening as I talked very fast. Do you guys have any questions, comments, or concerns? Dr. Ward says, we are still trying to figure out the way to best utilize hospital monitors in the ICU. Pulse pressure variation, optimal goals to treat a variety of diseases. There may be a select group of babies that benefit from home monitoring to get the biggest bang for the buck. And I totally agree. It's very difficult to assess these monitoring systems when what we're looking at as pediatricians is health outcomes, and there's just not good data there. So that may change drastically as more data comes out, but that's where we're at right now. Any other questions or thoughts?
Dr. Miller, I do have a comment. Thank you for this presentation. And I think the discussion about parental-based fear is an important one because that's really what's driving the industry. And the unfortunate thing is that the medical community has not yet come up with the proper studies or the best type of monitoring to really address how we decide which children are having true risk and following those outcomes properly. And so it's no wonder the over-the-counter market has boomed. And I just wanted to mention also, just like any other apps that we may agree to use, when we agree to use an app such as one of the smartphone applications for a monitoring system, is that there's a lot of detail in the user agreement that we commonly don't look at. And some of the monitoring systems used for children state that they use the metadata or they monitor the metadata from that. So that's something parents should be aware of as well.
Yeah, thank you for that, Dr. Tamez. You're absolutely right. And I meant to mention that Owlet, if you go to their website, mentions that their recording is like millions or billions of data points on babies every night. And that can be helpful when we're looking at these things that, like SIDS, that have a small prevalence in the population. We need big data in order to analyze them better. So that's not necessarily a bad thing. But we do, kind of as I mentioned at the end, need to be careful how this data is utilized, because it certainly could be weaponized as well as utilized. And we just need to be really thoughtful about where that data goes. And parents, as you mentioned, Dr. Tamez, need to recognize that that's a part of their agreement. And I also need to apologize. Dr. Tamez was my faculty mentor on this. I meant to put his name on the opening slide and forgot. I by no means mean to take credit for myself for this entire presentation. Dr. Tamez was extremely helpful in thinking through things and practicing and helping me find things like the Chime study. So I want to make sure I say thank you to him, and I apologize he's not anywhere explicitly in the presentation.
That was a very nice job and very thought-provoking for how we interact with our mechanical world.
Also, I think it would be undue without a quick shout out to Dr. Keys. I need to thank you, Dr. Keys, because we've had numerous discussions on the wards about pulse oximetry, its utilization, appropriate and inappropriate. And I appreciate how you obviously respect the technology and use it appropriately, but also are a proponent for finding ways to not misapply this technology and be really thoughtful about its application. So shout out to you as well, sir. You were a kind of a factor in coming up